Welcome, everyone, and thank you for being here today for the Division 40 Rule Advisory Committee meeting. It's been longer than we had attended originally since the last time we were all together. We do appreciate you still being available to participate on this important work. What we will do today is I'll share a screen. Today is mostly about having a conversation and digging into a little of the sort of high-level topics that came out of the last work that you did. And then we'll look at some of those other items. But when Sherry and I were working through the materials, there were some sort of underlying philosophical questions that we thought was important to discuss with the group, because we can go in a couple of different directions based on your input from last time. So with that, let me turn on a share screen. Move the windows where I can see them. Okay. And this goes through kind of the objectives that we want to accomplish for today. We want to step back and talk about some of the key questions or concepts, and we have some outside material that some of you had referenced, or based on your comments, we went out and found some references for it to discuss, particularly about this intersection of really supervision and documentation requirements. We'll go through some of those external materials. And then kind of the key question is this balance between sort of general or broad language and very prescriptive language. And the lens that we're thinking about this, well, one, there's a couple of places where we'll ask you, because in some of the sections we would get into it, and there's almost like both recommendations to go more broad or to be more explicit in the language for different reasons. And so it's kind of hard to figure out the driver behind what would be preferred or which direction we would go. So kind of the lens in us stepping back was to make it easiest or the least restrictive as far as like the concept of unnecessary barriers to regulation, that we don't want to have regulations or hoops that you all have to go through just to have them if they don't actually accomplish public protection, right? Or kind of the positive outcomes that we're looking for in a regulation. And so kind of that lens of, is anybody harmed by this being here or not being here? Or is it just kind of in the way and unnecessary? So does that framing or using our time today, taking this approach, is that okay with everyone? Yeah? Okay. Then the first piece, I'm going to scroll, so watch your eyes.
Michelle, can I just ask a question while you're scrolling? Just keeping roll of who's here. And I'm trying to figure out who's P37028.
Yeah, sorry about that. That's Joel Williams.
Okay, I thought it was. I just wanted to make.
I had trouble getting on today.
Okay, thanks, Joel.
R2D2's distant cousin.
Right.
Yeah. The first sort of underlying theme in the comments last time had to do with the whole concept of really terminology and what specifically is meant by reassessment as opposed to reexamination, as opposed to a progress note, reevaluation. And so some folks had referenced some of the other sources or the way these terms are used elsewhere. The other thing that's kind of interesting is that if you actually go out and search for reassessment at other PT boards, you don't really run into it outside of Oregon all that often. You run into other terms. And one word that we didn't come up with last time was this reference of the idea of reexamination, which is the topic that the APTA put out. I think they published this in roughly 2018. But this is how they're framing the idea of that initial examination, the concept of re-examination separate from re-evaluation in their language. And then if I scroll a little further, if we kind of key into that idea of Medicare's definition of re-eval versus a progress note. And this source with the link here, I thought did a decent job of trying to summarize all of the Medicare requirements in plain language, which is why I reference it here. But they talk about this idea of a progress note or an entry in the patient record that serves essentially as that roadmap or the ongoing documentation about the treatment journey, if you will. And it talks about the components here that make up a progress note in their definition. Pretty similar to some of the comments that you were making, like best practices or some of the requirements that you're facing in your different care settings. And then also getting into this concept of being really clear in how we're using this terms about what is billable and what's not billable. And so they talk about that a little bit. And then that gets into, and I think, Joni, you were one of the folks that was talking about the Medicare definition of reevaluation and those 3 triggers or 3 reasons that came up, which it outlines here. Kind of this could, if we go down this path, we could write plain language that maybe was similar to this kind of detail, or that's something to think about whether it's helpful to, if we go down that path, maybe map out these concepts similar to this, and kind of getting into, is one of the approaches defining progress note, defining reevaluation, defining whether we want to use reassessment or reevaluation. And if creating language similar to this is helpful, or just cite the different sources. And the last one I want to kind of throw out there, and then we'll have some conversation just at this point. This got into concepts around recertification. And so this is out of CMS and their specific 30-day reassessment requirements, yet another use of the word. And it starts to talk about these ideas that also came up about, at a minimum, every 30 days, in order to get to recertification. So kind of those with some external references, kind of what kind of thoughts do you have glancing through this material, or like the different approaches that we could take on kind of tackling these terms almost at a definitional level?
Just a quick question. I thought CMS got rid of the 30 days and it's just 10 visits. Does anybody else experience that? Or is it always 30 days for everybody else?
I thought it was 10 visits or 12 weeks, whichever comes first.
I thought it was 10 visits.
Are we talking about a progress note?
Yes.
Yeah, the progress note, I believe, is every 10 visits.
Okay. And I'm just going to make a notation there. So my apologies on having outdated language. Appreciate that, Scott. Just put a no there and then update it. Other thoughts on kind of these terms and maybe moving away from reassessment and moving kind of or referencing or creating definitions for concepts based on Medicare, the idea of a reevaluation, some of the definitions of progress note.
I can speak just to my experience with dealing with this recently in the last few months. And the reason I got into doing this, sorry, I just worked a full day. The board advisory rules committee was because my boss was asking me to co-sign progress notes written by a PTA. And I was like, I don't think that's allowed to happen. And so then I reached out to Sherry and she helped me with some guidance on it. But I actually sent my boss the board rules and I was talking to her about some of the language in it. And even she had said to me after I was like, let me see if I can find the message. Even after I had told her that the reassessment is a progress note, she still was like, I wonder what the definition of it is, though. Like a reassessment seems different to me than a progress note, unless there's a change in status. And so I think for her, like, even though I had expressed to her that those two words were the same, it still wasn't clicking for her. And she was still asking me, and she still felt like it was legally okay for the PTA to write the progress notes and for me just to co-sign them. So for her, it was still difficult for her to understand it.
Okay.
If we were to change reassessment to re-examination, would we also then seriously consider changing eval or evaluation to examination?
Thoughts?
Does it have to be either or it can be both and have an explanation of, or like a definition of each in the beginning of the ruling? I think if you have a definition on the top and then it clarifies what you're reading. I think reevaluation is where it comes on tricky. When it changes on the status, and then sometimes if people bill for reevaluation for while they're doing a progress note instead of like a change in status, that's where it kind of pops for billing, but I think if we put it in definition, it makes it more clear.
Okay. Joni?
I would just say it seems to make sense to try to marry the language between Medicare and state regulation, even CPT coding, right? We use evaluation, which describes that comprehensive service. You don't really see examination like in CPT language or even Medicare language. I'm just thinking what's easiest for practitioners if it was all the same or very close to the same.
Sure. Kathy?
That's exactly what I was going to say. I agree 100% with it being across the line CPT codes with Medicare, and then that's what we use in our clinics or hospitals.
Okay. I appreciate that. One of the, and when we look at some of the material from our adjacent jurisdictions, one of the other questions is as a compact state, and we know that we have probably somewhere around 20% at a minimum of folks that travel through that are licensed and practiced in multiple states. And you got to think, you know, it's difficult for them to even figure out A, where to look, and then B, figure out the difference between states when they're using different terms to say the same thing. So I think your points are both well taken, that if we can find sort of a broader standard, clearly define it in the different rooms, and if in the different terms, and if there's two terms that are interchangeable, to make that clear, to Cheyenne's point, right? So good thoughts. What else?
So I'm the person that's not a PT that supervises PTs. So I have to say this is just a little bit over my head at the moment. But as far as my school-based PTs, they don't bill Medicare or Medicaid at all. So I think what I'm hearing is that there's going to be more clarity if you align to Medicare, but it's not going to change how often they have to do a re-examination / reassessment. Is that true?
Well, I think we haven't talked about that piece of it yet.
Okay.
Yeah, and that
Okay.
they're not mutually exclusive.
Okay. Okay, that sounds good. I think that like from a school perspective, I'm not seeing an objection to changing the language. There could be a different conversation on frequency of visits, but we just don't bill Medicare, so it's not really part of my knowledge base.
Great. And I think your perspective as well, that, you know, we want the rules to be plain language enough that it's clear to not only PTs, practicing professionals, but folks that supervise them, patients that go in for care, right? So it's a good perspective. And when we get to the final version, that'll be a good test, right? Does this make sense? Is it clear?
Does Jessica know what we're talking about?
Yeah. Other thoughts? It sounds like there's general consensus on trying to align as much as possible with Medicare where that's appropriate, and then clearly define these other terms and move away from language that is somehow unique to Oregon. Okay.
Michelle, I think that's a really good point that you brought up to Jessica, because a lot of people have bosses or colleagues who are not PTs. And so I would love if the committee, when we get to the point of bringing things back and getting ready to finalize things, go to your coworkers, your colleagues, your boss, supervisor, somebody who is not a PT, and say, like, was it Cheyenne was saying, you know, her boss was like, I still don't know what that means, you know, even though you explained it to me. So that'd be a good test to say, okay, does this make more sense than what I showed you the last time we had this conversation? I think that would be really helpful.
Okay, I'm going to scroll again. Watch your eyes. Now what I want to do, this was a very eye-opening exercise in frustration, and simply just trying to find the answers to how this is handled in our neighboring states. And California in particular was very difficult, at least for me personally, to figure out even where everything was documented. And so that experience really underscores that even going through the rules, and would appreciate when we get toward the end of the process, input from you all on where, even if the way we provide links to the rules are useful, right? Or if there's different ways we could format it to make it more accessible, easy to find. So not really the content of Division 40, but just getting to the rules and understanding where to find them, where they're updated, and how to make use of them. So with that said, California, when you go through it, they actually ask for very little in the way of, or they refer to very little, or they're not very prescriptive, right, about what you have to do in a laundry list. So in going through the link, if you want to look at, they've put together a law guide. And if you look for concepts like patient record, evaluation, assessment, permanent record, I try to use search terms relative to what we were looking at. And they use patient record, and I'll just put this here. And this is pretty much the equivalent of standards for record, right? And we have a couple of different sections about what needs to be included. But this is almost the extent of the detail that they put into examination, re-examination, evaluation, re-evaluation. Even the idea of a discharge summary, they do not have a whole other section that talks about discharge like we do at this time. Okay. It is interwoven with their requirements with supervision, and that kind of the relationship between the what the PT can do or is responsible for and what a PTA can do. They do absolutely start to describe that, you know, the PT is the one that's responsible for compliance. They don't necessarily get into as much detail as Oregon does as far as the PT can do this or the PTA can document this, but not that. And this, you know, they sort of say the PT will make sure that all of this stuff is there and that it's accurate. And E here is something else that came up in some of the comments that folks had raised about that the PTA is responsible for notifying the PT when there's a change in the patient's condition that's not kind of within those parameters. So they set this up. The PT is in charge of the initial evaluation, setting the plan of care, and then the PTA can kind of go along on those rails, but is obligated to like bring the person back in, not on any fixed cycle, but when it's required. One of the important pieces, and that's kind of what this starts to get into, you can see part of this gets back into referral. California has direct access, but they don't have unrestricted direct access. They have this reference to 45 calendar days or 12 visits, whichever occurs first. And then it kind of has to loop back to the referring physician. That's not necessary here. So that one of the things to keep in mind in looking at any other language that we may want to model is to consider, are we more prescriptive, if you will, because it's open-ended? And so we have to have rules that set limits that, you know, where they have the max of the 45 days there or a number of visits there. We may not be able to just bring things in as is when we keep that point of context. So this talks a little bit more about doing that, how they do the referral, and they even dictate that you have to provide this statement to patients before you initiate care based on the referral, that you're receiving this from an individual who's licensed. You can receive it for so long. So they have this patient notification requirement around physical therapy services and what to expect. Then with evaluation, they talk about a PTA may assist in the provision of services under supervision, and that the physical therapist is at all times responsible for the extent, kind, quality, and documentation of PT services that are provided. And so this is where they create sort of an umbrella responsibility that there's flexibility in what can be documented by a PTA. It's just the PT is always in charge of that and making sure that it's accurate and appropriate. They do have a clause here about in Part D, a PTA shall not perform any evaluation of patient or prepare a discharge summary. The supervising PT shall determine which elements of the treatment plan, if any, can be assigned. So it depends. And I know that came up later, is that you really have to know and have a relationship. That supervising PT needs to know their specific PTAs and what they're capable of and what would be appropriate for delegation. And that's how they're describing that concept. So to get there, part of what they have, and all of this hooks onto the idea of what adequate supervision is for the purposes of the law. And here they talk about that continuing responsibility to follow the progress of each patient and determining what a PTA is doing. They're also a little different under Part B in that they require the PT who performs the initial evaluation to be the PT of record for that patient. Here, there's language that allows it to be that individual or whoever is effectively on duty that day for a piece of it. Something else to consider. And then it gets into more specifically of the things that need to happen, what a PTA cannot do. And then Part 3, I have it in here. It is really, it applies to AIDS. But I put it in there because it does talk about patient care related tasks. So what kind of like reactions or thoughts to California's approach to this do you all have? Things you like, things that you don't like, or even just questions that this raises?
Michelle, this is Jen Jokowski.
Hey, Jen.
I actually like the language of just making it clear that the PT is in charge of making sure that the documentation requirements are followed, and just like they do, deciding what the PTAs can do, what their particular PTAs can do. Maybe not, no, that might be too broad, but I do like the idea of just making it clear, let the PTs do, in their clinic what what they know, as long as it's getting done though to those standards.
Mhm. In that context, Jen, it's pretty open-ended except for, this part D here where it says,
Yeah.
and is that kind of what they've outlined here? Does that seem appropriate? If we took
It's Medicare that doesn't allow discharge summaries to be written by a PTA, right?
Yeah.
So we can't change that. Yeah.
Okay. Other folks like that approach as well, or anybody not like it?
I do like the vagueness. This is Kathy Wajaya. And I definitely prefer Oregon's therapist of record basically being who's in the clinic that day versus the one doing the evaluation, working in the hospital. That would be a constant transfer of responsibility.
Yeah. Okay, thank you.
Yeah, especially my like working as an on-call therapist and an LTAC, like I'm only there maybe once a month, so that would be very challenging.
Joni.
Is the therapist of record the same as the therapist who's supervising that day? And that's a question I don't know.
Can you say that one more time?
Well, therapist of record is it defined in here? Because it may be different than the person who's supervising that day, right? Like if a PRN therapist goes into a long-term care facility and they're there that one day, is that the same as the patient of record or the therapist of record who actually maybe wrote the eval?
Right. So that we need to make sure we're being clear about what we mean when we use those terms. Okay.
Yeah, I was wondering the same thing, because that would be so hard to have that person be in charge of the patient through however long the patient's there. But I wonder, I'll try to do some looking up here while we're talking of what that means, therapist of record.
Yeah, and it is, from what I read in California code, that's what they mean. That the person of record is the person who writes the eval, who's then responsible for delegation of any part of the plan of care to a PTA, and that they're the ones supervising that care. So that they do seem to pull it all together. I don't know if they have something else for like on call or, and I'm just making a note there. So that idea of like what we mean by therapist of record with regard to the file versus allowing that flexibility for supervision and how that gets documented. Okay.
And maybe same with who's responsible for writing that discharge summary.
Okay. And I think part of it, kind of going back in time, a lot of these rules, many of these are pretty old at this point. And I think many of them evolved out of this idea or like a one-to-one relationship, that a patient would go to a PT, they would get all of their care from that one individual, and then they'd be better, they'd be discharged, and life would go on. And then I think a lot of these rules were written before there were even PTAs, right, as a licensed position. And then we have the care, and then we have the modern healthcare system and how it really works, right? So sometimes on some of this, it's like maybe we need to like not try to edit what we have now, but kind of step back, describe how it works, and then develop the rules from there. I mean,
Yes, I was wondering if, based on what was brought up about asking a therapist to co-sign a note that was written by a PT assistant, if it would be worth to add that as, not only write a discharge note, write or sign off or co-sign
Okay.
to avoid any confusion.
Okay. So when can you do what? Okay. Joni.
I guess maybe one additional thing I like about this section is I do like that it kind of clarifies what a PTA cannot do, but I also like that it kind of gives the PT a little more leeway because it's written in a little more broad sense. And as someone else pointed out, the PT knows their PTA best. They know what they're really good at and maybe what they're not so good at, and feels more comfortable maybe giving them more complex acts. I don't know. I just think it gives the PT a little more autonomy.
Thank you. Would y'all like to see Washington State?
Yeah.
Watch your eyes. I can almost make it end up on one page, but so in Washington State, when you start with that idea of physical therapy records, which is their term, and that's what you need to do, what you need to include. You need all the stuff that's necessary.
That's kind of wow.
Yeah. And then both the PT and PTA need to recognize their professional boundaries and their own competence, which we talked about last time, looking for some clarity on what's meant by that, and that you stay within the lanes. Then they talk about some of the other things that we have in like documentation standards that they have under supervision responsibility. They do emphasize, like California does, that the PT is the one professionally and legally responsible for the patient care given by anybody else. So that would probably be the equivalent of when we establish the therapist of record. And then only the licensed physical therapist may do the following things. So California says PT is responsible for everything, can delegate to a PTA, but a PTA can never do these things. California says only a PT can do these things. So a different way of clarifying that. And I'll just scroll that. And I think, I'll just put that on the screen for a moment. I think one other thing note here under number 1, they do get into other sections that are more settings based, which we talked about doing, but in general, irrespective of the setting, this has to happen. So only a PT can which is interesting that only a licensed physical therapist may, and then we go down here, timely review of documentation, re-examination. I mean, it's not well written even. I'm not entirely sure what they mean by timely review of documentation there. That only the PT can do. They also have this idea of establishing a discharge plan, only a PT can do, but it's different from who can actually, write the discharge note or do something else there, which could be a different approach of if only the PT establishes what a discharge plan would be, but somebody else, it could leave open somebody else actually documenting that or implementing that, right? Effectively doing the discharge.
We kind of have that because right now it says that PT has to make the decision to discharge a patient.
Yeah. I'm going to scroll just a little bit here to get the rest of this up. Because this starts to talk about if patient care is given by a PTA or other assistive supervision requires re-eval, and here's where they do the later of every 5th visit or every 30 days. If the PT has not treated the patient in any of those 5 visits or within the last 30 days. It's a little unclear the way they have this written, whether those 5 visits could go longer than 30 days. I think it could be read either way, but I don't think I'd want to adopt this rule as written.
I think it would go more than 30 days because it would probably cover those patients that just come once a month or every other week or something like that.
Yeah, you would think. It's just when they added or if a PT has not treated them within the last, so it's weird. I think I know what they mean, but I'd want to write it better. And then here they get to that same kind of concept in B that they're sort of obligating the PTA that if there's a change in the patient's condition or anything that's happening that's not consistent with the plan of care, that they have to involve the PT at that point. They can't continue to proceed down the path or change the plan of care. Then you start to see their definition of patient re-examination. My
Mine did
connection
too. I
hung
think
up
it's
a little
R.
bit through the state.
Yeah.
Looks like everybody else. And if you're able to hear us, I think our Portland connection froze up a little bit. Okay.
I can still hear you.
Okay, good.
It's interesting that they say what a re-examination means in 3, but in 4 they talk about patient re-examination in 3, and in 4 they talk about reevaluation and don't define it.
Yeah. I also fully intend, we're going through this process and all of the work that you're doing, and we plan to also share this input and what we're doing with California and with Washington State, right? So that they know where we're headed, and then also some feedback on when we went through their things, some things that we had questions about or suggestions for them as well. So
I think part of the reason we even, explored into this is to see, are other states as specific as we are? And do we have to be as specific, or, are they just more generic or using definitions, or, how are, especially the bordering states, because we have so many people that go back and forth between those states working, they could be working in both states multiple times in a day, to be able to know, or, clinics that, go across state lines, the same company.
and that raises a little the question that we touched on before for folks that work here, travelers. Is there really something unique about practicing within the borders of Oregon that would drive us to have unique requirements? I could see maybe in specific care settings because of Medicaid or ODE, right? Something prescriptive there, but otherwise I'm not so sure. The kind of the last piece on Washington that I wanted to be sure to highlight here is that both California and Washington have language that limit the number of, here in Washington, you see it describes it as assistive personnel. Washington's limiting it to a total of 3 assistive personnel, inclusive of PTAs, any other staff, and aides. And there may be a trade-off in the level of specificity that they have for what needs to be documented and how, whereas Oregon, it's effectively unlimited, but no more than you can effectively manage, effectively supervise. So we did also want to have that conversation with you all, whether should Oregon have limits, supervision limits, or do we need more explicit language, prescriptive language, to offset or to help manage over allocation of supervision on folks that need to supervise? And part of what I'm getting to is that we occasionally get feedback that because it's possible, there may be an employer that requires a PT to take on an unmanageable load to supervise. Similar to having unmanageable patient loads, right? Expectations around productivity. And so can you be effective? Can you effectively supervise more than a certain number and be solely responsible for what happens? So I think that's part of why California and Washington are saying, here's the point where we think any reasonable PT can be effective in supervising and being responsible for that care through assistive personnel. And here in Oregon, we say, well, we're not going to tell you what that threshold is because it depends on the person and the people. So, but you can't exceed your own personal capacity. So thoughts on Washington, or sort of those philosophical questions that are being addressed?
I like the vagueness that Oregon has on that last point. I mean, if I'm working for someone and I don't think I can manage that many people, I'm going to leave them. There's plenty of jobs, and that's going to take care of itself.
Okay. Other thoughts on anything out of the Washington material?
I think having a definition of assisted personnel would be helpful if we were to use that sentence.
Okay.
Michelle, one thought I had is where they were talking about 3 assisted personnel. And my question was, what about students? And I see down at the bottom, I think it says, in addition to, you can have 2 students. So potentially 3 assistant personnel, and then 2 students. Is that right? Am I reading that right?
Yeah, so I think you could have up to a total of 5, the 3, and then the then the 2 students, unless in that part 2, unless you're in a nursing home, and then it's more restrictive. And that could be a consideration, you know, are there any care settings where it would be necessary to set limits? Or, you know, to Joel's point, is it, you know, it more appropriate to let the PT be the person that decides what the load that they can take on? Generally, what I'm hearing at this point is that the preference on that point would be to leave it as is, at least without further discussion or potentially in a specific care setting, but none that have been raised so far. Joni?
I was just wondering if anyone knows of, I mean, have there been any complaints or where, you know, someone was supervising too many people, and so the safety of the public was not what it should be? So, I mean, are there cases like that? I mean, is there any way for us to look at some basis of action codes or just Oregon's experience, or what does that look like?
I think speaking nationally, you know, comparing notes, that if I could answer your question more broadly in sort of types of violations, that it, particularly in the last, you know, 4 years, that that there are violations that appear to be a factor of pressures on the individual to do more than they're in that moment able to do. And that could include supervision. It can include difficulty or expectation on the use through the EMRs, and, you know, the timing for getting that, and productivity quotas, or even more broadly, just the effects of burnout on a one-on-one patient interaction. You definitely see that. It does tend to be individualized, so I'm not sure. I don't know that it translates or it happens in the same kind of fact pattern at a level where you can say there's a threshold. You know, that it should be capped at this number, because as soon as you get above that, then it can, we see more instances of violations. It really does seem to be based more on the person in the circumstance that they're in, and whether they feel comfortable saying no, like Joel said, and finding a different employer, or they feel that they just have to do more. And then sometimes corners get cut. Share anything else on that?
Yeah, you know, Michelle and I have talked about this quite a bit. It's really made me think, you know, when we look at the rules, like what are we looking at as far as public protection? And when I think about, you know, how many complaints we've looked at or I've investigated that deal with supervision or not documenting the reassessment or not documenting it, not discharging a patient appropriately, or anything like that. And I've had very few number of cases where like a PT should have been involved and wasn't, and a PTA just kind of kept seeing a patient and there was some issue with potential patient injury. But I don't know that that's necessarily doing the documentation of the reassessments. It's more that a PT wasn't involved in the care. And all the other ones that we've looked at that involve like whether someone is discharged or not. It sounds funny, but it's whether or not we've determined if someone has a sexual relationship with a patient, has that person been discharged, or are they still a patient? It's kind of what we look at, because the definition of who is a patient. But in general, we don't really see a lot of complaints about PTAs that are not being properly supervised, or PTs that are having to manage too many PTAs. I think, to Michelle's point, we've had some people who have spread themselves too thinly and have done things that they probably shouldn't have done, like falsify documents and made like they saw a patient when they actually didn't, because they needed to see 15 patients in a day and they just can't see that many. So they're trying to make their productivity quota, and for whatever reason, make a bad choice to think nobody's going to know they didn't actually see that patient. But it's really kind of made me think, like, what if our job is to protect the public, is having all these strict rules about documentation? I mean, OTs have not one rule on documentation, nothing. They're not required to document anything. and they're working in most of the same facilities as PTs, right? School, if you look at like SNFs, schools, places like the acute care, they don't have any rules on documentation. So, and the other point that, Michelle was showing things from CMS, and most people have other entities that are requiring them to document things. If you have Medicare, you have the insurance companies, you have whatever facility you're working in, you have federal regulations. So it's like there's already so many restrictions or so many guidelines that then we add ours, and if they're not exactly the same, it adds an extra burden to people. So I think it would be great if we could somehow streamline things so it's not so burdensome on people just to be worried about what they're documenting to meet the board's requirement when they already have to document for so many other requirements.
Yeah, I like the idea of it being more vague for that very reason, since there are so many other licensing bodies that we need to attend to, or regulatory bodies. And I think most sites tend to go with the most restrictive, right? So that you're meeting the needs of the most restrictive, everyone else is going to fall within that.
One of the things, Sarah and I were talking about that as we were going through your comments and thinking about this, is through that lens, as far as requirements for records and what has to be included or not included, that so many of the care settings are very specific about what that needs to be. And like Medicare, Medicaid, they have their requirements. Schools have their requirements, right? Hospitals have specific standards for patient records and what needs to be included. That from that standpoint, there's actually a very small slice that isn't documented elsewhere in other regulations. And that's private practice that is private pay, right? And so another question is there, from the standpoint of public protection, and if it's covered elsewhere, should we be vague and essentially say, that you have to have the appropriate level of documentation for the care setting that you're practicing in? If you are in private practice, private pay, here's what those standards are. because nobody else regulates that. What are your thoughts on kind of that kind of approach, Joni?
I work in a hospital system where there's 5 hospitals, and we don't have any standards of documentation for physical therapists.
Not even the standards in 333 for record keeping.
There's like, Medicare, which is again pretty
Okay.
vague.
Okay. Other thoughts?
I like that idea. I think it would be nice if it didn't call out specifically, this is for private practice, but again, left it open so anyone who didn't have another regulatory body they were held accountable to could utilize those guidelines or regulations.
Okay. And maybe keep it as like a minimum standard.
Yes.
Still kind of have some flexibility and not try to, it has to have it 14-point font. And I'm being ridiculous, but a reasonable requirement.
Yes.
Okay. Okay. So it sounds like folks would be open to us taking the approach of seeing, like, instead of being limited to the language that's on the books now and making edits here and there, kind of stepping back and having broader language where is appropriate, and then detailing out only where it's necessary, where it seems to serve a purpose for public protection. Is that an okay summary or a direction to take, Joni?
Just to clarify for me, so you're saying something more like California language where it says, okay, you document an evaluation and a reevaluation, and it's very vague, right? Treatment plan, discharge summary, and leaving it more like that.
Yeah, and if I'm misstating what I'm hearing, but that's the sense that folks are interested in being a little bit more vague, and then only being very explicit where is absolutely necessary. Seen some head nods and thumbs up. So, okay. And then this will come back to you. So if we've taken it too far where it's not useful, or it raises more questions, then we can add in more detail from that point. So I think what we'll end up doing is approaching it from both directions, starting from what we have and some of the edits that we identified before, but then also starting from some of these other sources and seeing if we can write clear definitions in plain language at sort of that broader level, to leave it up to the discretion of the physical therapist, right, in determining plan of care. Okay. I'm gonna skip over next steps for just a moment and talk about the rest of the document that we've sent out to you. And it was in the context of the existing rule language. What we did is highlight your comments in line. So permanent record is flagged because that was identified as something that needs to be corrected. And then we tried to reflect the comments that were raised under the sections where they were raised. So we're not going to go through line by line here, but the question that we do have for everyone is, if you look through these, if you look through the PDF that we sent out, and if you're seeing a key piece that's either misstated or we missed it entirely from your comments, and we need to make sure that we're considering a change or a clarification. If you would let us know. But otherwise, what Sherry and I are going to do is use the input from tonight's session, along with your original comments and for some folks, materials that you had sent to us separately in more detail, and massage this all into draft language. So I'm going to scroll back up, watch your eyes. So once we have all of that, one of the tests that we need to do is a test against the ORS, or the Oregon Revised Statutes, or statutory limitations. And what I mean by that is, and I'm going to scroll again. You'll see the other thing that we've started to do in what we've given you is record, for example, from when it says from MPA, that's the Model Practice Act. We can push it out again. We had dropped it into the chat at the last meeting, but we can send the link out again in case you don't have that. Because the Model Practice Act is intended to be sort of the statute, or the ORS, and what we're working on as rules, is we can take this definition, but we need to, anything that we're proposing, we need to match back against the statute to make sure that we have legislative authority to make the change. If we don't, we can still flag that as something that would require a statute change to accomplish. So your input and everything will still go forward to the board, but it would just be flagged as we can't do this as a rule change without that statute changing. So I'm going to scroll back, watch your eyes. So then our intention is to take all of this and send back the results of that work to you by the 18th of October. What we'd like to do is see if it's possible, or, well, we want to ask you first, we can either set up another meeting on the 24th, 25th, or 28th to talk about, as a group in the meeting, the draft that was sent to you on the 18th for folks that can make it, or we can not even set up another meeting and just have everyone send back written feedback by approximately one of those days. Do y'all have a preference about whether it's useful to come together as a group to talk through the final draft? Or would you rather not even schedule something?
I always like the group.
Same here.
Okay.
I agree.
Okay. Joni?
Would it be optional, like if you wanted to send comments, like if those dates weren't, okay, yep.
Absolutely. Absolutely. And that's why we can send out a survey to see which of those days works best. And Sherry and I can see, if comparing notes, if we can eke out any other days in about that time to put on offer, but it would be optional. And then what we would do is we would set the deadline for written feedback the day before that meeting, just so we would have time to compile anything that's coming in before for the group to go through. Then at that point, we would then commit to getting you back the final document that would be going to the board for your review by the 8th of November. Part of that gap is the Federation annual meeting is in between those two bullet points. And then any kind of final comments or edits that you have on that document, we would need back by the 12th of November so that we can put it into the packet for the board members. And it would be presented to the board at their November 22nd, which is a Friday morning there. RAC members would be more than welcome to attend and even talk to the materials, but that is not required either. The document would represent the work of the committee and those recommendations, and that's what would be presented to the board.
Just want to add that it's a Zoom meeting. And usually this part would start like 9-ish, no earlier than 9-ish. So if anybody wants to come participate, you can be there for the whole public session meeting or just this portion of the meeting. But I personally would love to have a couple committee members there. So when the board asks some questions, we have people there who participated, who could speak to what we talked about other than just me and Michelle.
Yeah.
How long is that meeting?
This the meeting goes from 8:30 to roughly 12, depending on how much content the board has. We would probably schedule this for this portion would probably only be, depending on discussion, I imagine like 45 minutes. And we'd probably schedule it right around 9 o'clock. Any kind of questions on kind of the timeline or where we're headed and when we're headed there? Okay. I am going to stop the share. And then just double check if there's anything else at this juncture that any members of the committee would like to raise. Because otherwise, I think we have what we need to do the next step. And we could go ahead and get you back to your lives a little earlier than planned, if that's okay.
Michelle, is there a timeline that we would want everybody to review what you sent out today and get things back to us so we could start drafting things?
Yeah, I'd say we'll start drafting, and our target is to get everything back to you by the 18th. But if you have time even later this week to do a quick scan in the rest of the document that was sent out to see if anything's missing, only because the sooner we have that, we can make sure that we incorporate it. But if you don't notice something till later, that's totally okay as well. And I believe the 18th is a Friday of that particular week. Okay. Then I will go ahead and stop the recording for the meeting today.